treatment of gouty arthritis. The objectives as per our musculoskeletal block includes classify the drugs commonly used in the treatment of gout, mention the indications, adverse effect, dosage, and toxicities of drugs used in the treatment of gout, design a plan for the treatment of gout, prescribe the appropriate treatment for different cases of gout, enumerate the tests required for monitoring the therapy of gout. These are the objectives as per the our block. The guideline as per the British Society for Rheumatology and British Health Professionals for Rheumatology indicated some guidelines for the treatment of gout. As per this British Society for Rheumatology and British Health Professionals for Rheumatology, the treatment of acute gout includes treat acute gout with non-steroidal anti-inflammatory drugs, corticosteroids, colchicine, and continue until attack is terminated near about 1 to 2 weeks. The goal of treatment is the relief of pain and inflammation. It is not necessary to lower the serum uric acid immediately. Non-steroidal anti-inflammatory drugs are the drug of choice, provided no contraindications for the use. And the most important is use colchicine in doses of 0.5 milligram 2 to 4 times daily. This low dose oral colchicine is effective as and safe without toxicity. Colchicine has an adverse effect of diarrhea. In taking with the consideration of diarrhea, the use of colchicine should be recommended. The first drug is non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs are the preferred first-line therapy for the treatment of acute gout. provided no contraindications for the use because of effectiveness and tolerability. If there is a contraindications for the non-steroidal anti-inflammatory drugs, then avoid it. All non-steroidal anti-inflammatory drugs are equally effective in patients at a risk for gastrointestinal toxicity from non-steroidal anti-inflammatory drugs. Appropriate gastrointestinal protection should be used, means antacids should be used, including proton pump inhibitors. Examples are omeprazole, rabeprazole, paraprazole, or some antacids like ranitidine or cimetidine. Non-steroidal anti-inflammatory drugs should be avoided in patients with heart failure, renal impairments, and elderly. As we know, these non-steroidal anti-inflammatory drugs decrease the vasodilating prostaglandins and may decrease the EGFR rate. Thereby, it should be avoided in patient of the renal impairment and the elderly, and plus in the heart failure patients, because non-steroidal anti-inflammatory drugs may inhibits the COX-1 in the various smooth muscle and thereby may increase the adverse effect. COX-1 plus COX-2. Non-steroidal anti-inflammatory drugs are safe for patients with the stable controlled hypertension when given for only a few days and with close monitoring of blood pressure. Second drug is colchicine. Colchicine is effective for acute gout but slower to work than non-steroidal anti-inflammatory drugs. Use colchicine in doses of 0.5 milligram 2 to 4 times daily. Avoid dosing more frequently every 2 hours to prevent adverse effect of diarrhea. Mechanism of action of colchicine: inhibits the microtubule polymerization, thereby decrease the action of inflammatory mediators such as cytokines and chemokines. The adverse effects include diarrhea, nausea, and vomiting, alopecia, and decrease in bone mineral density. According to the European League Against Rheumatism Guideline, the colchicine is the first line drug for the treatment of gout. Remember, according to the European League Against Rheumatism Guideline, colchicine is the first line drug for the treatment of gout. Here we just discussed non-steroidal anti-inflammatory are the preferred first-line therapy for the treatment of acute gout. If the question is which one of the following is a first-line therapy for the treatment of acute gout, your answer should be non-steroidal anti-inflammatory drug. But if the question is specific, like here, according to the European League against rheumatism guideline, which is the first line agent for the treatment of gout, so your answer should be colchicine. Corticosteroids, as we know that corticosteroids having anti-inflammatory activity, corticosteroids are effective for acute gout in patients who cannot tolerate non-steroidal anti-inflammatory drugs or are refractory to other therapy. Corticosteroids is given by intramuscular, intravenous, or intra-articularly in monoarticular gout. Treatment of hyperuricemia to prevent recurrent gout. Start uric acid lowering therapy 1 to 2 weeks after inflammation has resolved. Hyperuricemia, hyper means increase, uricemia means the increase in the uric acid in the blood or serum. So how can we manage the uric acid level normal in the blood or serum? We need to start uric acid lowering therapy, or we can say urate lowering therapy. Start urate lowering therapy means the drugs which lowers the uric acid in blood 1 to 2 weeks after inflammation has resolved. The first management here is to decrease the pain and inflammation. So after the inflammation has resolved, start urate lowering therapy with plasma urate goal less than 300 millimole per liter, or we can say less than 5 milligram per deciliter of the blood. Indications of urate lowering therapy includes one or more acute attack within 12 months of the first attacks. It means that 2 or more attacks occur per year. If the patient is complaining of 2 attacks in 1 year, then there is an indication of urate lowering therapy, the drugs which decrease the uric acid level from the blood. The patient has comorbidities at the first acute attack. The comorbidities include uretrophy, uric acid stones, and chronic kidney disease. If the patient has these comorbidities, then we need to start urate lowering therapy. Third indication is some medications increases the uric acid in the blood, or we can say some medications may cause hyperuricemia, and if these medications need to continue in the patients or need to continue medication that cause hyperuricemia, examples are diuretics, thiazide diuretics and the loop diuretics, furosemide, hydrochlorothiazide, chlorthalidone, aspirin, cyclosporine, cytotoxic chemotherapy, levodopa, ethambutol, and pyrazinamide. These are the drugs which increases the uric acid in the blood, or we can say these are the drugs that are responsible for the hyperuricemia. If the patient on this chronic drug therapy, and these drugs are very important for the patient, we are not able to discontinue the drug, then we need to add urate lowering therapy. So let us see the drugs which are used as urate lowering therapy, treatment of hyperuricemia to prevent recurrent gout. The first drug is allopurinol, which inhibits the xanthine oxidase enzyme and thereby decreasing uric acid formation. Initial urate lowering therapy, initial urate lowering therapy should be allopurinol, starting with 50 to 100 milligram per day and increasing by 50 to 100 milligram every weeks until therapeutic goal of serum uric acid less than 5 milligram per deciliter or less than 300 millimole per liter, and the maximum dose of allopurinol should be 900 milligram per day. When initiating allopurinol, prevent gout attacks by giving colchicine 0.5 milligram twice daily for up to 6 months. When initiating allopurinol to prevent the gout attack, that is urate mobilization flare, by giving colchicine 0.5 milligram twice daily for up to 6 months. If patient cannot tolerate colchicine, nonsteroidal anti-inflammatory drugs or specific COX-2 inhibitors, that is cyclooxygenase inhibitors, can be substituted but limit to 6 weeks. If the patient is not able to tolerate colchicine, use non-steroidal anti-inflammatory drugs or specific COX-2 inhibitors. Examples are celecoxib, can be substituted but limit to 6 weeks. If an acute attack occur while on allopurinol, do not stop allopurinol but treat acute attack as usual with non-steroidal anti-inflammatory drugs, colchicine or corticosteroids. The side effects of allopurinol includes fever, rash, hypersensitivity reactions, hepatotoxicity, vasculitis, and the worsening of renal failure. So the patient of hepatotoxics and the renal failure, the great care should be cautioned while prescribing allopurinol. Second drug is febuxostat. Febuxostat, more selective xanthine oxidase inhibitor than allopurinol, used as an alternative to allopurinol in patients allergic to allopurinol or patients with renal impairment if creatinine clearance is more than 30 ml per minute. We can say which one of the following drug is used in the patient where allopurinol is contraindicated. So your answer should be febuxostat is used in the patient for the treatment of hyperuricemia as a urate lowering therapy in which the allopurinol is contraindicated or not working. The dose of febuxostat is 40 to 120 milligram once daily. Side effect includes diarrhea, headache, and the liver function abnormalities. The plus point of febuxostat is it can be used in the patient if the creatinine clearance is more than 30 ml per minute. And it should be avoided in the patient with liver disease. Next drug is uricosuric drugs. An example is probenecid. As the name indicates, uricosuric drugs, they bring about the uric acid into the urine. That's why termed as uricosuric drugs. Uricosuric agent should be used only as second line drugs in those under excreting urates and in those resistance to or intolerance to allopurinol. So remember, the probenecid is not a first line agent in the treatment of hyperuricemia. It is used as second line drug, and when there is the excreting urates, because it's an uricosuric, so it bring about the uric acid into the urine. That's why uricosuric drugs. Next drug is rusburicase. Recombinant urate oxidase is an enzyme which is responsible for the convert uric acid to allantoin, and which is 5 to 10 times more soluble than uric acid. We can say rasburicase is a drug which converts uric acid to allantoin, which is a 5 to 10 times more soluble than uric acid. And what is the advantage of more solubility? Rapid renal excretion, rapid reduction in the serum uric acid within 4 hours of administration. And the plus point of rasburicase is it can be used as urate lowering therapy if creatinine clearance is less than 30 ml per minute in the dose of zero point 0.2 milligram per kg by IV infusion for 5 days. Rasburicase is also indicated in the treatment of TLS, that is tumor lysis syndrome. Adverse effect of rasburicase includes allergic reactions, rash, nausea, vomiting, and diarrhea, and headache. In patient with hyperuricemia without any previous acute attack of gout should not be treated with urate lowering therapy, example allopurinol. What is the note? In patient with hyperuricemia without any previous acute attack of gout should not be treated as with urate lowering therapy, means should not be treated with the allopurinol, because there is a no acute attack of gout, there is only hyperuricemia. And sometimes the hyperuricemia is due to the some diet, maybe due to the some drug. So in this case, if there is only hyperuricemia and there is no acute attack of gout, no need for the urate lowering therapy. After discontinuation of the drug or maybe the food, this uric acid level will be normalized. Because what is the drawback for urate lowering therapy? Urate lowering therapy, once started, it should be taken for lifetime, and that's why no need to take urate lowering therapy if the patient is having hyperuricemia without any clinical indications of acute attack of gout. A large percentage of hyperuricemic patients may never experience an acute attack of gout, because sometimes increase in the uric acid level may be due to some foods, some diet, and some drugs. Adjuvant therapy to prevent recurrent gouts. The most important is lifestyle and dietary changes to prevent further acute attacks of gout. Moderate physical exercise, additional therapy to prevent recurrent gout, gradual weight reduction, and it's important avoid rapid weight loss because rapid weight loss may form ketosis, and this ketosis may increase the uric acid level. So that's why gradual weight reduction. Total daily purine intake should not exceed 200 milligram per day. If there is increase in the purine intake, there may be the increase in the uric acid formation. Avoid shellfish, sardines, soft drinks, and alcohol as they may increase the serum uric acid. Avoids the liver and kidneys, reduce the intake of red meat because the red meat, liver, kidneys, these increases the uric acid level high. Limiting daily purine rich meats and fructose containing beverages, foods, and limiting intake of alcohol also helpful in reducing the serum uric acid, as the lifestyle and dietary changes are very important factor to prevent the further acute attacks of gout. Adjuvant therapy to prevent recurrent gouts, management of hypertensive in gouty patients. Now, as we seen, some diuretics are responsible or some drugs are responsible for hyperuricemia. Thiazide should be switched. Thiazide diuretics, chlorthalidone, hydrochlorothiazides, chlorthalidone. Thiazide should be switched to another first-line antihypertensive drugs as thiazides increase the volume depletion and decrease the renal secretion of uric acid. Recommend the use of losartan and amlodipine. Losartan is angiotensin receptor blocker and amlodipine is a calcium channel blocker, as both drug decreases the serum uric acid. Amlodipine increase the GFR rate and decrease the serum uric acid. Losartan increase the renal excretion of uric acid by interacting with urate 1 protein in the proximal tubule of the nephron. So if the gouty patient is on the thiazide diuretic, switch to the angiotensin receptor blocker or calcium channel blocker. Examples are amlodipine and losartan. Management of hypertriglyceridemia in patient with hyperuricemia. If the patient hyperuricemia patient is on the therapy of dyslipidemic drugs, the drugs which decreases the lipid fibrates, examples are gemfibrozil and fenofibrates are recommended for the treatment of hypertriglyceridemia in this patient, as they also decrease serum uric acid concentration by increasing renal urate excretion. So it means that if the patient of dyslipidemia on fibrates, if the gouty patient of dyslipidemia is on fibrates, it's okay and recommended, because fibrates drug decreases the serum uric acid concentration by increasing renal urate excretion. So which drugs should be avoided from the category of dyslipidemic drugs? Niacin is commonly used for the treatment of hypertriglyceridemia, but niacin should be avoided in the treatment of this hyperlipidemia of this patient, as niacin is responsible for increase in uric acid level, we can say hyperuricemia. Thank you very much. Any questions?